Thank you, Dr. Stan. Uh, Ladies and gentlemen, as Dr. Stan had advised, that we'll be having an interactive session. We invite you to feel free to engage with us. But of course, to engage with me, I was advised when I was young, I was told when I was young, I think it's across all cultures that we grew up knowing not to speak to strangers, you know. They'll tell you, don't speak to strangers. Just go to the shop, come back running. Back then, there were cars, valiants, the black ones. For some reason, they were the ones who were kidnapping kids. But today's time, you know, they are quantums, they are what? They are white. Heroes come in different colors. So I'd like to introduce myself so we can engage better. My name is Khautsang Samurai. I'm the provider liaison officer. I see our next speaker as well is Khao. I was having a conflict with him that no, we can't have the same Khao. It's mine. I came first, then you be Khao after. But ladies and gentlemen, this next doctor, a credible speaker, I asked him when he came in, I said, Doctor, why do you choose medicine? He said, Khautsang, my story is very simple. When I was young, my grandfather wanted me to be a doctor. So he always motivated me and pushed me to become a doctor. But by the time I became a medical doctor, he was no longer around. He had passed. He was not around to see my success and what he was building me to. Then he said, Khautsang as well, as you can see, I'm an eye specialist. It's not a coincidence as well. I didn't see an opportunity and become an eye specialist. My grandmother was there to see my success, which was something else as well. I got joy from that because my grandfather couldn't see that. But then my grandmother was blind. So that actually motivated me to become an eye specialist. So, ladies and gentlemen, with that, with the human element, let's welcome Dr. Khaukhelo Edward Moleleke Lekhodi.
Good morning, everybody. And thank you, Khao Tsang. Myself, I'm Khao Gelo. Yes, I'm the man from Limpopo. I'm here from here, Keraimo. I hope you can all hear me. As they've already introduced me, that I'm an eye specialist, I'm an ophthalmologist. Yes, it's true. Because of my grandmom was diabetic before he passed on, and she was blind because of diabetic retinopathy. And that time, the only doctor of eye specialist was Dr. Khosi Letlape. And it was not easy because he was always fully booked. That's why my topic, I think on the agenda was written red eye. I just said, no, man, at home, I want to talk about diabetic. Because yes, I'm in Pretoria, but the patients that are coming from home, Limpopo, with diabetes is starting to increase. I really don't know why, but we have to look into it. Especially far north, Ilim, Luitrichat, Tando is starting to be worse. Let's start. Diabetic retinopathy is the commonest cause of blindness in the population of working age in developed countries and also in developing countries. The prevalence of diabetic retinopathy of any severity in the diabetic population is 30%, and the prevalence of blindness due to diabetes is approximately 5%. Personally, I feel that it's even more than that. Diabetic is a global epidemic with significant morbidity. That one, we are aware of it. And retinopathy is a specific microvascular complication of DM and affects 1 in 3 persons per DM. You may find that almost most of us in this room were diabetic. Let's not go there. Diabetes remains a leading cause of vision loss in working adult population. Patients with severe levels of diabetic are reported to have poorer quality of life, reduced level of physical, emotional, and social well-being, and they utilize more healthcare resources. And that is true, because if you can look at it, besides retinopathy, there are so many things that to deal with the social workplaces, to do with emotional things, loss of libidos, loss of most of the things that you'll be happy to have them. Unfortunately, you don't have them because of diabetic. Epidemiology studies and clinical trials have shown that optical control of blood glucose, and also blood pressure, and blood lipids can reduce the risk of developing retinopathy and slow in progression. You know, these things that I wrote there, I don't know why they are intermarriage. Either if you've got glucose, if you've got diabetic, you've got hypertension and lipid. Why? I don't know why. Why are they close? It's hardly that you can find hypertension alone, but yes, it's there, but you know, I usually ask myself, why are they so related? The diabetics military's timely treatment with laser photocoagulation. By the way, here I'm talking about diabetic retinopathy. On the side of ophthalmology, what do we do? And increasingly an appropriate use of intraocular administration of vascular endothelium growth factor inhibitors can prevent visual loss in vision-threatening retinopathy, particularly diabetic macular edema. As time goes by, you'll be seeing what I'm talking about. Since the visual loss may not be present at the earlier stages of retinopathy, regular screening, ladies and gentlemen, is needed. I'm going to stay on this picture. I want you to understand it so that you can have an idea what I'm talking about. Let's start with the first what can I say? This first picture. This one. At first, because of the diabetic retinopathy, you start to have hypoxic retina, and that hypoxic retina leads to AV shunt. And after the AV shunt, it leads to vasoformative substances, which lead to rubeosis iridis. Rubeosis iridis. Therefore, there's vessels on the iris, and we don't want them there. And later, at the back of the eye on the retina, you have what you call proliferative retinopathy. I don't know if I can able to. The problem is that you aren't able to hear me properly. Now the second diagram, it shows what's happening to the arterioles and the venules. On the side of the venules, where is written occlusion? What occludes those vessels is that the basement membrane is thickening. Red blood cells also are having changes, and platelet thickness is increased, blocking the vessels. They're blocking the arterioles. They're leading to occlusion. Then on the side, there's also leakage on the venules, whereby there's a leakage of that because of loss of pericytes. The last part, that's where you, the doctor, see on the patients with diabetic retinopathy, where you're going to see retinal edema, exudate, retinal hemorrhages, which we are going to talk about them now. Now, here I just put all the complications that can cause by diabetes, whereby it's diabetic foot, diabetic nephropathy, peripheral glaucoma, cataract, the list go on and on and on. Let's look at the first one, whereby this patient here is amputation, is diabetic. Here, third nerve palsy. Patient has got squint sort of like because of third nerve palsy. Here is diabetic cataract. Here is central retinal vein occlusion because of high blood and diabetic. On top there, they've got glaucoma. Now, let's come to the classification of diabetic retinopathy. Those who are older than me, they all used to talk about background diabetic retinopathy, you know. Unfortunately, that one is gone. And now we are talking of non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Eyes with non-proliferative diabetic have not yet developed neovascularization. That one that I was talking about, I said vessels on the disc or rubeosis iridis. They have not yet developed, but have any of other classification of diabetic lesions, meaning that you see some dots on the retina, the red dots meaning that they've got only of retinal hemorrhages. And the eyes progress from having non-diabetic retinopathy through a spectrum of diabetic severity that includes the mild, the moderate, and the severe. This one is more on the side of the ophthalmologist. You just know the picture, what you see on the retina. This is what, remember I said, please look at that diagram of pathogenesis. These are the things that, remember I said I talk about exudates. If this is a yellow part, that is caused by those parasites, loss of parasites, RBC changes, and those type of things, they lead into that. This is what you, the doctor, are going to see, that they've got red microaneurysms, they've got blood hemorrhages, and exudate. And when you see a patient like this, please refer, because we need to start them now from here. Then as it goes by, those exudates are becoming worse and worse, and that is leading to the blindness of the patient. Remember, the person who can stop or at least retard the poor vision of the patient, it's you, by referring. Now I'm going to proliferative diabetic retinopathy, whereby this one is becoming worse. It's the most advanced stage of diabetic retinopathy and represents angiotic response of the retina to extensive ischemia of capillary closure. And this is where you're going to see what you call new vessels at the disc. Let me go here. If you see here, this is an optic nerve. And there's these new vessels, these small vessels, you know, like spaghetti, like, we don't want them there. We really don't, because they are fragile, they bleed easily. And as time goes by, there's another one where we call NVEs, where therefore neovascular elsewhere. We don't want them, because as they bleed, they're going to lead into this, what you call pre-retinal hemorrhages, and then from there, it's going to be a disaster. Now, the other one is diabetic edema. It's also our nightmare on the side of the ophthalmologist, because it's very difficult to treat it. This is just an additional important complication that is assessed separately from the stages of retinopathy, and it can be found in the eyes at any diabetic severity. Even without having those hemorrhages, you may just have this diabetic edema alone, and it's a disaster. Currently, diabetic eyes are generally classified as having no DM, non-central involved DME or central involved DME. This is for us mostly. I'm just wanted to let you know what diabetic edema is. It's something like this, whereby on the macula itself, macula is the thing that makes you to see clearly those blue colors very well, those red colors, white very well, because of the macular edema, of the macula, sorry. And if the macula is having a problem, your vision is also going to have a problem. And with advanced diabetic eye disease, these are the things what you are going to see. You remember I said that picture of pathogenesis? Here it is again. This is what I was calling about rubeosis iridis. The patient is starting to have vessels on the iris and they're going to bleed, and the patient is going to have a painful red eye because that blood inside is increasing and increasing. And the patient, most of the time, when at this stage, they will tell you, "Doc, can you please just remove my eye and throw it away?" And unfortunately, that's most of the time where we end up to. Now, the stage after this part, if the patient doesn't get treated, we are going to so-called end-stage diabetic retinopathy, whereby I think you've seen a lot of patients like this in town, anywhere, or in your practices, whereby the eye is become tricycle, is become smaller, is non-functional, is vascularized cornea, no visual potential. This one is dead for good. Nothing can be done. The other option is that for cosmetic reasons, whereby we can remove the eye and put a marble in the eye. Should the patient be seen earlier, could be avoided. This thing could have been avoided. Now for you, this is the diagram. I'm not going to go through it. You can take a picture. This is a diagram. I so wish that when you see a patient or you hear a patient is diabetic, has got diabetic mellitus, and ask the patient, when did you last seen by the sort of an optometrist or an ophthalmologist, or you as a practitioner can help us with this. I'm still going to come about that what can you as a general practitioner or a physician or whoever on the health sector, what you can do to help us ophthalmologists to refer the patient at an early stage. Now, the treatment of diabetic retinopathy is mainly on the side of an ophthalmologist. But what do we do? The first thing is up on your side, whereby please optimize that medical treatment of the patient, also to look into the HB1AC so that it cannot be high. And with associated treatment on hypertension, lipids, and please don't forget the diet and psychosocial management of the patient on the side of the social worker. Because most of the patients, they don't do well because of also the psychosocial part. Like eating at home. I mean, the patient is diabetic. You are not diabetic, but you are eating the things that, the diabetics must not eat. Please work with them, in such them to help them to eat the right things. No DR, mild or moderate or non-proliferate diabetic. Follow at recommended intervals. This is the diagram that I was talking about. Follow the intervals. If it's 6 months, please do that. Try by all means to help the patient. I know some patients can be stubborn, but also help them. Make them aware what the situation they are in. And on the other side, we do a lot of imaging, and we do a lot of lasering of the eye, and also giving injection into the eye so that we can retard the progression of the diabetic retinopathy. There are benefits of early pan-retinal photocoagulation at the severe non-proliferative stage of patients with type 2 diabetes. Other factors such as poor compliance with follow-up, impending cataract extraction or pregnancy, status of the fellow eye will also help in determining the timing of the pan-retinal photocoagulation. Pan-retinal is for us whereby we do laser into the retina to burn. I usually give an example of saying, if we're looking at the movies, when the patient bleed, or for you because you are a medical practitioner, cautery. It's like cautery, using a gunpowder to put and burn it, so that you can stop the bleeding. Laser photocoagulation is nearly the same as that. treatment with a pan-retinal flocculation, there's increasing evidence of clinical trials that when we treat this patient like this laser and anti-VEGF, honestly, it does wonders. Anywhere, wherever you go. And I've seen the patient, and I'm happy about that. This is a picture of a patient after the laser. If you see those black dots around here, these are laser. What happened? We've lasered the patient so that to decrease the bleeding of the patient from diabetic retinopathy. Now I want to talk to you. There's this thing. Direct ophthalmoscope. I bet you almost all of you have got it, and it's gathering a dust somewhere. The battery are finished. It's sitting there inside next to the bed. I can see it. When did you last touch it? You know, something like that. And that thing is very important. Please do me a favor. If from here you're going to the surgery, please change the batteries. Just change those batteries. Put new batteries. Put it in. Look, it's just the light. Then you do. Okay. Start with your children, your wife, your husband. Nana, look there. The left eye with the left eye. The right eye, you look at the right eye. Don't be afraid to be next to the patient. Start looking at the optic nerve. Move around, look at the vessels. You'll see some dots around. I bet you. One day when you meet me in Savannah, you'll say, Doc, it works. Just this. Direct ophthalmoscope. You've got it. It's there in your rooms. Please, once you do that, most of the patient will be helped because you'll be able to refer those patients at an early stage. Ladies and gentlemen, this is where I stop with diabetic retinopathy by showing what you can help us to help the patient so that they're not getting blind. Please, let's help the patient. The challenge that we have is that, as you heard the principal officer of JEBS complaining about, abuse. Sometimes they will end up thinking that we ophthalmologists, we are doing abuse. And why? Because here is a complicated case. It keeps on coming and coming. You do it, it bleed. You do it, it bleed. Should we have stopped at the earlier stage, we will be where we are with the patient, because we are trying to fight for the patient to become better. The challenge what we have is that if we don't treat that patient, no matter, we know the outcome of the thing is that in terms of the vision, is that the patient is going to develop what you call neovascular glaucoma, which is a painful red eye because of increased intraocular pressure. I see complicated cases every day. The days where I just cried, I said, I don't know how to help this patient. But I have to do them. He's all the way from Elim. He tells me that, Doc, I use the train, after a train, taxi, just the whole day on the road to come and see us. And when they arrive, I cannot help them. How painful it is. Usually when I operate them from my heart because of the way I saw my grandmother going down because of diabetic retinopathy. It's painful. That's why at the end, I end up having a hospital where James asked me to say something about it. Because it's home here, I can be at peace that at least somebody from Limpopo started something like this. for our own people. I'm going to play this video.
The Mpudule Eye Center is licensed to have 3 theaters, 6 beds, and 3 recliners. The center's main activity is specialized eye services. These are ophthalmological cases, which are mainly diseases in the eye and refraction of the lens, and require surgery to correct. Other more serious conditions may require meticulous microscopic surgery, which may not restore vision, but could improve it effectively. With an abundance of technologically advanced state-of-the-art equipment and highly competent eye care professionals, the Mpudule Eye Center is said to be a leader in the elimination of avoidable blindness by providing reliable and efficient eye care services.
As the name entails, Mpudule, open my eyes so that I can able to see. It's a pretty name. And this is the thing that I wanted you to know. Working together to save the patient's avoidable blindness. I need you. Let's help them. Is any question? And by the way, to start this was not easy. It led me to have high blood, all type of psychological problems. I think some of my classmates, I can see them here, probably they know. I see Dr. Bombi is there, Thomas Bombi, Dr. Mpake is there. They were my classmates. I was one of the youngest in class, anyway, with very naughty ideas anyway. Ladies and gentlemen, I'm happy to hear any questions from you because we still have time. But if not, I can go down.
Thank you very much, Dr. Khao, for the presentation. Ladies and gentlemen, any questions? When I started the Matume story, it was intentional for this. We are here to create an enabling environment. Psychological safety comes first. Don't be shy to ask questions. So, should there be questions? I'm sure it was an interesting topic by Dr. Khao. The Khaos are like that. We ask. But with that, ladies and gentlemen, any questions? Please raise your hands. Kevin, can we start here?
Thank you for the good presentation. I'm Dr. Legala. I just want to know the location of your clinic. Is it the Mpudule we know next to Mostorlos, or it's Mpudule in Gauteng?
Is Mpudule
Sorry to disturb. We are on video as well, and for our technical team as well. When you're asking your questions, ladies and gentlemen, please stand up and so that the team will be able to see which mic, the color coding is different as well for the recording. Thank you. Apologies for that.
Okay, I'm Dr. Lucia Legala. I just wanted to find out the location of the hospital. Is it the Mpudule we know next to Mostorlos, or it's in Gauteng?
Is the Mpudule the one from Pretoria North, Lady Selbon? Cederberg. Is not far away from Acacia. I don't know if you know Acacia. On the mountain, you can see it. The Mpudule one there, that side. Bosele, my grandfather is the one who named it. Bosele, for the blind, in Mostorlos. I'm aware of it. And I visited it several times. Thank you.
Thank you for the question.
Thank you so much, Doc, for the presentation. I think I enjoyed it. I'm Dr. Zianda Makaba from the Managed Care Organization. I think my question is for the benefit of the general practitioners that are in the room with regards to, screening of diabetic patients for any ophthalmological conditions. Do you have an advice of, if they already are taking care of diabetic patients, how often should they be dusting that ophthalmoscope and making sure that we screen on a whatever basis, if you can just say that, and then what are the signs that should then warn them that this is a patient that needs to be seen by an ophthalmologist, as opposed to, they still have time, because they have to juggle between who needs to be seen by ophthalmologists, who they can still manage. Is there any telltale signs to say, now this is the one that you must send to ophthalmologist? Thank you. And how often?
Let's start. First of all, that direct ophthalmoscope must not have a dust. Secondly, I think there's a diagram that I said, please just take a picture of it when to refer the patients to the challenge is that I know, and I'm not blaming you, ophthalmology is only for 2 weeks during our training. You cannot learn a lot. Look, for me, I did for 4 years, just for an eye. And I understand the challenge that we may have. The advice that I can give it to you is that you can go and buy what you call 1% tropicamide. It's an eye drop so that to dilate the eye, so that you can see better. Immediately you see some things that you don't understand, please just refer, because you as a general practitioner, you cannot do anything, because with us we've got those laser machines that when we see we have to do something right now. With you, you're just going to look and just refer, no matter how it's like. Rather, save the patient that they say, I'll refer, until the poor patient is becoming blind. And the interval, I usually say, let's say you see the patient for the first time, that is diabetic retinopathy. Just for the first time, let them go and see the ophthalmologist just to take the photos and everything, because what I do, I take all the photos of the patient and frequently I monitor them. Is progression or no progression? I'm very aggressive because I've seen if I try to be lenient or I look into what the book says, it tends to be worse. I hope I've answered all the questions. Thank you.
Thank you for the question. Kevin, you have a question?
Good morning, everyone. This is Dr. Innocentia Mashiro. I'm a dentist. Thank you, Dr. Khao, for the beautiful presentation. As a dental professional, we have been seeing a lot of diabetic patients. Diabetes is terrorizing the oral cavity. So now, I'm actually conflicted in which order of referral do we follow as the non-medical healthcare professionals. I'm a dentist. I'm going to look into the oral cavity. But then sometimes when I see my patients, they might not be at the stage of any signs of eye problems. Ne? But I would advise them to go to maybe a medical doctor or an optometrist. So I'm confused which order or the protocol do we follow when it comes to referral, because I like what you're saying when you're saying we need to help the patients. So we normally just refer to the ones that we know, we don't know if we can directly refer to you as a specialist, or do we follow the normal routine that we're doing, and how do we make sure that our patients are really taken care of? Because I'm just going to do my part, but then I leave the patient as they are. But to my surprise, sometimes you'll find, or you'll see the patient deteriorating under your care, but there's nothing you can do because you don't know anything about eyes. Thank you very much.
Thanks, doctor. I hope I still remember, between the medical side and dentist, we used to divide, we used to split at the 5th year. Is it 5th year or 4th year? I feel that time already know a lot of things, as a dentist. And that's number one. Number two, I'll feel comfortable for you to refer the patient to the nearest general practitioner next to you. Then they can be able to do their own part, because as you saw that, to treat a diabetic patient, it needs a team. It's not only about ophthalmology, it's a team. It's a team of general practitioners, it's a team of social workers, it's a team of at home, your wife, your husband, your children, list go on and on and on. But personally, I feel that referring the patient to your nearest general practitioner will be the best idea. Then, general practitioner will, this time I know the direct endoscopy is not have dust. They'll look at this thing and they can refer the patient. Thank you.
Dr. Brenda has a question. Kevin?
Thank you. Okay, I'm Dr. Brenda Kubega-Chauke, and thank you for an insightful presentation. I'm sitting here and thinking of the ethics surrounding preventable blindness. And the question that I have is, what should we walk out with after today? As reminders, how often should these eyes be looked at? And then secondly, if like some of us, ophthalmology, 2 or 4 weeks, the confidence is not there a role of using technology for the sake of the patients, especially those patients that have to travel distances to go see an ophthalmologist? Is there a role of technology like AI-enabled, whatever, and maybe also the collaboration and working with the optometrist, putting the patient at the center and making sure that blindness that is preventable indeed gets prevented? Thank you.
Thanks, Dr. Kubega-Chauke. I usually say the ethics start with your conscience. Do the right thing. Let's also help our medical aids to have that thing of we've got this decrease of unethical things that sometimes we do. Let's have conscience. We're dealing with the patient. That's number one. Personally, the problem that I have is that here is a patient, I can see he's about to go blind. Doesn't have medical aid. Does he have a cash? What am I going to do? It's a challenge. That's number one. Number two, you talked about how frequent should they refer the patient? As I said to you, or to all of you, I said, the best thing to do is that here is a patient is diabetic. First of all, please refer the patient to be seen by either optometrist who's got all these things, the gadget, or ophthalmologist, the gadget, to take photos. Because for me, I like taking the photos so that I can continue looking at the progression. You talk about AI. I don't know how many AIs we've been trying to do. All of them failing. I don't know, it's us, we are not, I don't want to say computer literate, or we're all on the WhatsApp, on the TV, and all these things. I remember when I was in Natal, we used to have this telemedicine thing. It works, it works, it doesn't work. It works, it doesn't work. End up, it's getting dust like direct ophthalmoscope. Those machines. Honestly, I can give you an example. We've got this, what we call fundus photos cameras, which each and every one, they're not that expensive. I don't know what's meaning of expensive anyway, let me not go there. I'm just going to say it's not that expensive, so that you can have them, so that you can take a photo and send a WhatsApp. Hey, doc, I see a patient here with this, can you do? How many of us have? And some of you have got it, really. I remember there was some of the optometrists, even today, I've never even seen those patient photos, but they've got those fundus cameras. I don't know what's going on with us, honestly, with that, but it will work. It can save a patient's distance from Elim to come to Pretoria. But it's us this time. It's nothing to do with the patient. It's nothing to do with something. It's us with the AI. I hope I've answered you.
Thank you very much for the question. Let me start this side just to ensure that we don't pass anybody else. I note your hand. This side, any questions? No questions? Hosi, we have a question there. Thank you.
Hi, my question is quite simple. I wanted to find out how often do you do pro bono cases in order to reach those very people that need them, that do not have the capital capacity to afford your, your services. Yes. And how to mitigate the transportation issue.
The pro bono issue, we usually do it around October during the Carthage month when we gathered and talk with the industry. Because remember, it needs a lot of checkup. The challenge also with us with the pro bono, do you know that the pro bono, in case, I think Dr. Kubeka Chauke can even say it, even if I've done the patient for free, the patient can litigate me. And those are the challenges that we have. There's cases whereby people have done cataract operation and it didn't go well. They had a complication. The same patient with pro bono didn't pay a cent, and the hospital did this and this and this, they litigate. Then those are some of the things that end up making doctors so afraid to do pro bonos. That's number one. Number two, answering you, on our side, we do it in this way. It's mostly cataract operations, because to do retinal operations, it's very expensive. I don't want to lie to you. It needs a lot of things, because remember, we're operating a case. We take about 1 hour to 2 hours to do the case. We have to put oil, we have to put laser, and that oil needs to be removed again at the later stage, and all of them, James is going to complain, but doc, you keep on operating and operating and operating. Now, here's a patient pro bono. How are you going to keep on operating and operating on the patients? There's pros and cons in so many things, but yes, I do them, but I select. Honestly, I do select. I sit down with the patient, I explain to them, because if I have to do, because I do a lot of retinas, I said, if I have to do retinas, you may find that I'm going to do 5 retinas on one eye, 5 operations on one eye, because of to try to sort out the problem. You see, those are the things. Transportation, yes, sometimes it depends where is it. We sometimes do transport patients to come if they need to be serviced at our place. I hope I've answered you. He said so, I don't know. I'm trying to be legally right here, I can't just, I've got people with ethics, lawyers are here and all those things. I have to be very careful the way I answer.
Thank you very much.
My name is Dr. Mkhadini Chinyani. I'm a fetal medicine specialist. I have an interest in diabetic, and I run a diabetic clinic in pregnancy. My question is about, one, it goes to GEMS to say that, do they have a benefit during pregnancy whereby when we diagnose women that are not known to have diabetes during pregnancy, and will label them as overt diabetes because they have no history of diabetes during pregnancy? But usually you can see this looks like a long-standing diabetics. Unfortunately, we're seeing it in pregnancy. Do they have a benefit for eye examination by an optometrist or ophthalmologist, especially in the lower benefits of the GEMS? Number two, I want to ask Dr. How does pregnancy affect the proliferation of the retinopathy during pregnancy? Or do you wait after pregnancy to examine them, or the examination is still the same, or does pregnancy affect it? Number three, I think I'm getting a little blind because the screen is too bright and I can't see.
I think the first question was to do with GEMS. I'm going to answer on my side of the ROP. ROP is another problems that we have on the side of litigation in this way. ROP most of the time are premature babies. That's why we call it ROP. ROP means retinopathy of prematurity. It's common on the children who are premature. Now, the challenge that the lawyers have seen a gap on the way, who to sue, a pediatrician or an ophthalmologist or the hospital. Why? I want to explain to you. That ROP most of the time is the cause of oxygen. Did you hear me? You don't give the oxygen, the child dies. You give the oxygen, ROP. Now, lawyers, they are the people who cause us problems, honestly, because we end up, there's a word, that we, much okay, that we use to say we do preventative medicine. Defensive medicine, sorry, yeah, defensive medicine. Because now, before I see you, I said, oh, by the way, the lawyers, what are they going to say? If I see you, the lawyers are going to say something. I said, no, I can't do this. I don't know how to do it. But answering you, yes, we see the patient with ROP. We have to do the laser around that periphery so that it must not be worse. Now the challenge with if the child has poor vision, so Madanga Commission comes in. That's the problem. Okay, thank you, everybody. I see they say time's up. Go away from this platform.
Okay, thank you very much, Doctor.